Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, HeHe. Now let's get to the good stuff. Kayleigh, welcome to the show.
Hey, HeHe, thank you so much for having me.
I'm so happy to be here. And honestly, I feel like this is a long time coming. I feel like we should have had you on the show a long time ago. I think for a lot of people, this is a scary topic or a lot of people have never heard of AFB. A lot of people don't even know that this is a possibility. They don't even know that it's a thing that happens, which good, right? It's a very rare thing. But part of being an informed consumer is having the discussion of those scary things, knowing that they can happen. And then also something that you and I both value really highly is helping people understand what are your options if this does happen to you, and also what can you expect from your care if something like this happens to you. I think a good place before we dive into your story and hear your experience, could you break down what is AFB and what does it mean for the pregnant person? What should be in our head and in the forefront of our mind in terms of AFB in labor?
It's a great question. And I want to start with, obviously, I'm not a medical provider, but
Neither one of us are.
I have done some extensive research on amniotic fluid embolism and work really closely with the foundation. When we're talking about amniotic fluid embolism, I like to say the name is a bit of a misnomer because it is not an embolic event. There is not a physical blockage per se that is causing the event itself, the cascade. And so what it is most like is an anaphylactic type of reaction to amniotic fluid or fetal material that enters into maternal circulation. The caveat being that amniotic fluid and fetal material is found in like 99% of people who are pregnant, giving birth, etc. So it's not the act of it entering into the system, into maternal circulation. It's that a really small percentage of us have a really big immune response to that. And that immune response typically happens in two phases, which is the initial, for some people it's cardiac arrest, but it's like a hypoxia, hypotension that leads to respiratory distress, and again, often cardiac arrest. And then the second phase, which is disseminated intravascular coagulopathy, which is DIC. That is a very dangerous bleeding condition. And so essentially, your body creates all of these microclots, consumes all of your clotting factors, and then you bleed out, massively bleed out. And that can be really difficult to control for providers. Anesthesiologists crassly refer to DIC as death is coming.
Wow. Very scary. Oh my goodness. Okay, and can we as consumers expect that all of our medical providers are familiar with AFE and that all hospitals are trained to handle this situation? Or are we finding that more so like academic medical centers or hospitals that have really high volumes of births are going to be more equipped to handle situations like this?
As with any catastrophic complication, which AFE is, the higher level centers are going to just be more equipped to deal with them because of the technology that they have access to. Things like ECMO, things like codes that are run by several different disciplines, blood banks that have lots and lots of blood product. Now, that doesn't mean that someone can't survive an AFE in a more kind of community-based hospital. I was actually at a community-based hospital.
Okay.
But yes, the higher level facilities are going to have more options.
Mm-hmm.
But really, what we see, so I didn't really mention this, but unfortunately, AFE is unpreventable, unpredictable, and often fatal. So that means you won't know who it's going to happen to and when it's going to happen. So teams have to respond within seconds of a patient going down, recognize that it could potentially be an amniotic fluid embolism, and then do all of the supportive measures because we have no treatment for an amniotic. Like we can't, if we look at preeclampsia, we can treat it somewhat with MAG, right? Magnesium sulfate. We don't have anything like that for AFE. There's nothing that can treat it, just supportive measures to deal with. Obviously, if someone goes into cardiac arrest, we are doing everything that we know with a CLS protocol, specifically for a pregnant person, and then dealing with the breathing issues and dealing with the bleeding issues. But we don't have any way to reverse or treat an amniotic fluid embolism. And again, we are going to have more technology at those higher level places, but it really comes down to practice. It comes down to simulation.
Oh,
The way that we are going to best prepare to hopefully save a pregnant patient and a baby that's going through an amniotic fluid embolism is to practice what that looks like in your facility based on what technology, what team you have available. And actually, we have simulation guides on the AFE Foundation website for any level facility, which is the coolest part.
would you say that this is a newer phenomenon, or has this always been around and it somehow is just still a mystery to us?
Yeah, so the first recorded AFE was in the 1920s.
Wow, so actually it's not new.
No, it is not new. The pathophysiology, I can't quote the exact year, but the pathophysiology, understanding it as an immune system response rather than an embolic event, is newer. Like we are developing and understanding more things about it, but it's women's health. So
Way behind, no money. Who cares about women's health?
and not only is it women's health, but it's an incredibly rare complication. We're not talking about preeclampsia that happens to 200,000 people a year. We're talking about something that happens to 100 people in the US a year.
Wow, it's that rare, huh?
Yeah. Mhm.
Wow. Okay. And you had just mentioned having staff that recognizes it. What else may they think is going on and not recognize AFB for actually what it is?
That's a really good question. Definitely more of a medical question. But if we're doing a differential, anything that could cause a pregnant person to go into respiratory distress. So PE is one that is really, what's the word for it? Mistaken.
That's
So
pulmonary embolism.
embolism, thank you. Yes, a pulmonary embolism can sometimes present similarly, and the treatment is very different.
Oh, okay.
So we actually talk about this a lot when we call in, when teams are called in, like when a code team is called in, if you have someone coming from critical care, coming from ED, they're not necessarily going to think AFE because they're going through they're not L&D focused. They're not thinking about obstetric complications per se, even though the patient in front of them is an obstetric patient. That's not what they're used to, but they're getting called in for a code, which is a very rare event in L&D. And so we really stress this like at A1 when we were talking to nurses to be the advocate for your patient to be like, hey, what if it's an AFE?
Ah,
Because that will look different and the treatment for that patient will look different. But the people who are going to know and be focused on that, maybe an OB isn't in the room yet. Maybe who knows what's going on. Maybe they don't have an OB that's in hospital at all times. And so the people responding to that code are not obstetric focused, but the nurses in the room are. And they're the ones that can speak up and say, hey, what about an amniotic fluid embolism? What do we need to do for that?
got it. Wow. Okay. Super rare. I can see how it can it has almost slipped through the cracks. It makes sense, even though it feels really crummy. Okay, we have this almost always fatal thing. We need to pay attention to it, but it makes sense how, since it's so rare, the research industry is almost like, why would we pay attention to it when we have all of these other things that impact so many more people? Maybe not to the severity though. So that's definitely a conundrum. Okay, would you mind sharing your story with us? And for listeners, look, if this is too tough, please hit pause, take a moment, go get a sip of water, take a nap, stop listening for today and come back in a different day. You can always fast forward through Kayleigh's story too and hear the rest of the episode. I never want you to feel like you have to listen to things that might instill fear in you, but just know that Kayleigh and I are both sharing this story because we want you to know what your options are and how this might impact your labor if you were to experience it, because we want you to stay in control even if scary things happen in your labor. So that's just my little disclaimer.
Yeah, and I definitely want to get into the things that can be done or the things that you can advocate for beforehand, etc., if you're thinking about these types of things. But yeah, so I had a really normal pregnancy, pretty typical, no real concerns. And then 40 weeks and 2 days, I went in for an appointment and I had a high blood pressure reading in the office, waited till the end, even higher at the end of the appointment. And I was sent to triage, which is protocol because past due, they're just not really interested in messing around with hypertension, which I can understand. And I went into the hospital. I talked to some of my team. I will also say I actually don't have any memory of this. I don't have any memory of 10 days of this whole event. So I don't remember going to this triage appointment. I don't remember going into the hospital. But I have lots of text messages to friends and family, and I also have medical records that I have reviewed. So I talked with my team. We made the decision because of the gestational hypertension and the risk related to that, and actually because of my concern of how big my baby was, which is really interesting because I think we talk a lot about teams pushing for things like induction because they think the baby is too big. And I was actually reassured my entire pregnancy that he was measuring right on track. But I was like, I feel like he's huge. So, you know what, I'm already here. And I was a little bit worried about the hypertension, as was my team. So I was, let's go forward with an induction. I felt very well informed. So I unfortunately was like, 0% zero dilated, 0% effaced. So it was a long, slow process. I remember my one doctor telling me, listen, the riskiest thing for us to do is rush this process. Long and slow is actually the name of the game. As unpleasant as that might be for you, the biggest predictor of us heading in for a C-section is us rushing this process or trying to make it go too fast. So I was like, okay, cool. I understand that. So again, I'm not going to bore you with those details. The whole kind of Cervidil overnight, Cook's catheter, Pitocin, epidural, all the things. And then when I was 10 centimeters, finally, I had woken up that day like 7. By noon, I was 10 centimeters. My OB at the time came in and said, you're ready to go. Finally going to meet your baby. It was 2.5 days after the Cervidil had been placed. So 2.5 days after heading into the hospital, I was finally 10 centimeters. And my OB left the room to go gown up and get ready. I'm sure she assumed it would also take a while. My son was also OP, which was not super helpful for the pushing phase, I would assume at least. And then so when she left, I turned to my nurse and I said, I'm not feeling well. And she said, okay, that is normal for transition. I'll get you a bag to be sick in. And I said, nope, something is very wrong. And she went to glance at my vitals. And as she did that, I started screaming that something was wrong with my heart. And then I immediately went into cardiopulmonary arrest. So my heart stopped and I stopped breathing. And so my nurse at that point hit the code blue button. Teams came running in. There just so happened to be a critical care team on the floor in a meeting that day. So they all came in. They were able to get me out of my room within about 30 seconds and down to the OR. And my son was delivered within 6 minutes of that code call, which without a doubt saved his life. He did very well. He was 10-14, so I feel like I did win on that. My intuition about how large he was correct. But yeah, so he did really well. He did need to be resuscitated, but he bounced back quite quickly. and he was taken straight to the NICU just on some oxygen. And at this point, CPR had continued towards the end of my C-section. As my OB was sewing me up, they were able to get ROSC, which means I was able to be resuscitated. And at this point, my OB recognized I was likely having an amniotic fluid embolism. And she prophylactically called for a massive transfusion protocol and put in a Bakri balloon, even though at that point I was not at all bleeding. And a few minutes later, I did go into DIC, and they collected about 5 liters alone through the Bakri balloon in the first hour. And I did end up needing about 143 units of blood product by the end of this ordeal. At this point, they were trying to figure out how to stop the bleeding, and they were having a tough time. I went into cardiac arrest again. And at this point, I actually have a podcast with my OB, who's just such a lovely human. And at this point, she actually left the room to go talk to my family. And in what I like to call a very human moment, she had talked to them a few times before and updated them. And in this moment, she went and she said, "We can't stop the bleeding. We need you to pray." And she went back to the OR, and most of the people, there were lots of OBs who had come in to help. And most of them were preparing her for the fact that I wasn't going to survive this second cardiac arrest. Thankfully, I did. They were able to resuscitate me again, but they knew they needed to do something pretty drastic. And again, this was a community hospital. So they were a trauma too. So they had a significant amount of blood, but they didn't have things like ECMO. So they called out for ECMO, and the ECMO team came about an hour later, and I was cannulated for VA ECMO for both heart and lung support. For those who don't know, ECMO basically takes all of the blood out of your body, oxygenates it, and puts it back in. So it's the highest form of life support. It's very risky, but it keeps people alive in these very catastrophic situations. So once I was on ECMO, I was at least hemodynamically stabilized, but my heart wasn't recovering and I was still bleeding profusely. So they took me down and tried to embolize my uterine arteries. That worked, but not enough. And so they had to take me back to the OR and do a hysterectomy and a right salpingo oophorectomy, which is the removal of my right ovary. So I was left with one ovary, which is great for just hormonal reasons. And then I was packed and left open for transport. And then when I was transported to that next hospital, I had a lot of issues with my heart. So I needed much more support for my heart. There was a lot of conversation about if the Impella device didn't work, that my heart would clot and I would not survive. So that thankfully worked. I was able to come off of ECMO 2.5 days later. The Impella was able to be removed. On the 4th day, I think, I was able to be extubated. And then on the 5th day, I met my son, Callahan, for the first time, which was incredible. Yeah, so there's a lot more, obviously, to the story, but that is the basics of, I ended up being discharged after 2 weeks in the ICU, which was much sooner than we had expected. And that, for a lot of people, is where my story ended, because I survived something that I shouldn't have. And I survived cognitively intact with no long-term complications. And that's also not often the case with an amniotic fluid embolism. So for a lot of people, it was amazing. And for me, I was even oh my God, we're going to sail off into the sunset together. I did die and I came back to life, and now I get to be a mom. Imagine my dismay when quite the opposite happened, because I was so incredibly traumatized, and I was not alive when my son was born. I didn't get all of these first moments. I was in a coma. It was beautiful when I met him for the first time, but I don't remember it. There's beautiful videos and pictures. And so there was so much grief, and I was also still really physically recovering. So it was pretty difficult to be present. I couldn't take care of my son for a couple of months.
Oh, Kayleigh, your whole story is just so touching, and I've heard it before, right? I've heard it on
Yeah.
your podcast a million times. I heard it at A1, and even now I find myself tearing up, just how scary that was, and how I don't know, it literally changes your life, right? That is just so tough. So I have a couple of questions about your
Yeah.
story, but I want to say 2 things first. A, your OB is some sort of freaking special angel unicorn
She
person.
is.
What? It just
Yes.
really, it makes me say, who run the world? Kayleigh Summers. Not even
Yes.
girls, but like Kayleigh Summers run the world.
Okay, but also my OB, my trauma surgeon, and my interventional cardiologist were all women. And they were like the three key people who saved my life. There were
That's
other people too. I don't want to
great.
discount them, but
But to have three powerful, just super intelligent women working on you must feel very special. And just I hate to say people are lucky, but how lucky were you that critical care team just happened to be on the floor at the hospital on the day that you were going to push? You had already been there for 2 to 3 days. What if
yep.
they had not, what if they had chosen the day before or 2 days before or the day after? It's just all the stars aligned
Yep.
there. And then my second point is maternal estimation of fetal weight is the most accurate, right? It just is. We know
Yep.
notoriously ultrasounds can be off, and we
Yep.
see there's variation in that. You get people who are told their whole time that they have a big baby and they birth a 6.5 pound baby, or they're told the whole time it's a 7 pound baby and they birth a 10 pound baby. We see that happen a lot with ultrasounds. But I tell you who's almost never wrong. Mom. That
Mm-hmm.
mom that is carrying that baby, she knows that baby is part of their body. It is literally inside of you, how big your baby is. Was there any piece of you that wanted to push back on your providers, or did you just trust them and you were like, okay, if you're not worried, then I'm not worried?
I am always worried.
Yeah.
So-
Naturally anxious, same.
I'm a naturally anxious girly. You could not offer me enough reassurance that so I knew he was big. I just didn't care
Mm,
that because nothing was going to change the kind of like I didn't want them to say, "Oh, you think he's big? Let's induce you early." That was my I don't
okay.
want that. So the fact that they were like he's measuring right on track was a little bit invalidating. Like it
Oh,
definitely felt like a little invalidating. I don't think he is though. But there
okay.
didn't feel like a reason to push back
Hmm.
because it wasn't going to change my course of care in a way that I wanted it to.
Yeah.
So I was just like, I just think he's big and I guess we'll all see. But I did have concerns about, I have, I had a lot of weird intuition thingies that I believe were intuition, but also confirmation bias exists. So who knows? But I have lots of texts to my best friend talking about hemorrhaging, being really worried about bleeding, and having a bigger baby is a potential risk factor for bleeding more in my mind back then. I don't know what the actual research says about that, so I want to be careful. But I
Mm,
had read somewhere back then that there is a higher risk for postpartum hemorrhage if you have a larger baby based on the way that makes your uterus. And this actually did play a role in my case because yes, I had DIC, but I also had a very big, very tired uterus because I had been laboring. I had contractions for a significant amount of that time. And I just had a very large baby. So the uterine atony also played a role in the DIC. So back to my point, I was texting my best friend, being like, I think I'm gonna hemorrhage. Like I'm so worried about hemorrhaging. I'm worried about bleeding, and I'm worried that my big baby is going to play an impact in that. And she was very reassuring, as best friends should be, that you don't even know that your baby's big. Like I hear you, but we don't know that yet. And also, people are not just like hemorrhaging all the time here. Like it's a rare occurrence, et cetera, et cetera. That did not reassure me. I continued to think that I was going to hemorrhage.
I love you, but you're not making me feel better.
Yes. Yes. If you're listening to this, Jessica, you're amazing and I love you, but she already knows. Yeah, to your point, I actually forget how I got on this tangent, but there was some intuition there for me as well that I did feel like something bad was going to happen to the point where when my care providers were like switching off, they were like, she's like really anxious, like more than like first time mom anxious, like something's going on. And I don't think they thought something medically was going on necessarily, but they just were like clocking it. That's how bad it was at that time.
And for you, did you feel just so extra anxious, or were you almost gaslighting yourself, being like, this is probably normal? Like, I'm baseline anxious, and like now, obviously, I'm being induced. I've been here a while, like, I'm about to push out a baby. Our life is about to totally change. All right, of course, I'm going to be extra anxious. How was that inside of your body? What were you telling yourself? Did you recognize it as, whoa, this is a ton of anxiety?
I don't remember.
Ah, is that retrograde memory loss normal? Are we finding that with a lot of AFB survivors?
Here's my opinion. So a lot of us have some sort of memory gaps. That's a very large. The last thing I remember is getting my nails done on a Friday. That appointment was on Monday. So I had an
Wow.
appointment, I had 2.5 days in the hospital, and then of course, like we would expect once I went into cardiac arrest, I wouldn't remember anything.
Mm-hmm.
But it's a little, for me as a trauma therapist, I think that a significant portion of it is trauma related. Because when I first woke up, this will be of interest to the trauma people out there. When I first woke up, I could not remember a single prenatal appointment
Wow.
for 9 months. I could remember other stuff within that 9 months, but for the first few weeks, I couldn't remember what my doctor's office looked like, and I couldn't remember a single prenatal appointment. So it's like my brain tried to cut out the part about pregnancy when it tried to cut out the birth part. I
Isn't that
did get that back.
insane? Our
Yeah.
brains are so protective of us. That
Yep.
is the wildest thing to me. I just find my first degree is in psychology, child
Yeah.
psychology. So not it's human psychology, but not adult psychology. But
Yeah.
it's just so weird to me how our brains will do almost what it needs to do to protect us and to get us to survive, right? Okay, that was bad. That was really traumatic. We're going to erase those memories. Let's move on. Let's keep surviving. Let's get to tomorrow. Let's get to the next day. How do we keep this human thriving and surviving, even though we just went through something uber traumatic?
Yeah. Absolutely. It's wild. And I have never gotten those memories from that 10 days back. Not a single blip.
You think you ever will?
At this point, no. And for a long time, it's a huge part of my trauma to not remember. It's when you black. I don't know if ever. I shouldn't assume that you've blacked out from drinking before, but I have.
Yes, I
And and you know how it's like kind of anxiety provoking.
have.
Like there's this, yeah. So it's like that, except the most important moments of your life.
And something that you held as like very special and happy
Yes.
and joyous, something that
Yes.
we're all conditioned to really relish in and remember and hold these memories very close. And then for you to have nothing, it must feel very just unsettling.
It's very unsettling. And it's very, this will sound weird to people who have been through labor, but I do not remember a single contraction. I don't know what a contraction feels
Mm,
like.
mm.
And I went through, I can imagine because I had Braxton Hicks, but it's not the same thing. And I went through 2 days of labor. I don't remember, and I never will because I had a hysterectomy. And I think that there is definitely some loss in that place as well.
Yeah. Oh my gosh, I'm so sorry. Okay,
It's
I have
okay.
a question about induction because I know
Yep.
all of my listeners are thinking, if Kayleigh hadn't have been induced, this probably would never have happened. And I have to be completely honest with you, for a little bit there, when I first learned about your story, I held that same belief until I learned a little bit more
Really.
about AFB, until you shared a little bit more about your story, until I became an avid listener of your podcast. I did think, okay, obviously, anytime we intervene with induction, this makes sense. But something I've since learned is this can happen outside of induction. It can happen with C-section. It can happen with vaginal deliveries. Talk to us a little bit about that. It seems like you were very informed. You felt very confident in the decision that you made. Yours was a medically necessary induction. That's a tricky space. We don't want to
Totally.
keep going on with pregnancy when we need an induction, but obviously induction comes with risk. Talk to us about what we're seeing in terms of not necessarily causation, but what's the correlation between birth interventions and AFE?
Yeah. So what I always like to say is anything that is going to cause more of a likelihood of that amniotic fluid, fetal material to enter into maternal circulation at like higher volumes is going to potentially increase the risk of an amniotic fluid embolism. So any kind of like surgical birth any kind of like intervention. However, we don't have really significant data on things that definitely increase the risk for amniotic fluid embolism. So we have some factors that we talk about that could potentially increase the risk, induction being one of them, but not enough for us to change a recommendation in care. And so when we look at this, we have a handful of studies, and these will get cited all the time when people come at me in my comment section saying induction causes amniotic fluid embolism or induction increases the risk of amniotic fluid embolism. My argument for that is, one, the data is not great, and two, okay, but people actually still need medically indicated inductions.
Totally.
So sure, I don't think that we should be coercing people into inductions that are not medically necessary, but I think that without AFE.
Yeah.
So like
It's just a baseline thought.
it doesn't really change. Yeah, it doesn't really change at least my approach to birth in general. But some of the studies that we're seeing that people will cite show a doubling of the risk for an amniotic fluid embolism. So induction may double the risk of an amniotic fluid embolism. And people will cite that exact thing in my comments. And what frustrates me a little bit is for people who maybe are not as familiar with research or as familiar with amniotic fluid embolism, is recognizing what doubling means in the context of an amniotic fluid embolism, because it's tiny. Because an AFE is already so rare, doubling that risk is like incremental. So we're going from 1 in 40,000 to 2 in 40,000. So yeah, could it? And again, we have another side, a handful of studies that refute that basis. And we will always have that, at least right now, because it's so rare and because it's a diagnosis of exclusion. And so we do have some cases that are labeled an AFE that are not an AFE, which can mess with the research, which is why we now have inclusion criteria for inclusion of AFE cases into research, making sure they're meeting the criteria for an amniotic fluid embolism.
That is so interesting. Do we see any sort of link between big babies and AFE? Because you had just mentioned, I read big baby can increase your risk for postpartum hemorrhage. You're completely correct with that. We know that bigger babies come with a little bit of increased risk. You have increased risk of all sorts of things, developing gestational diabetes, preeclampsia, hypertension, shoulder dystocia, longer labors, uterine atony, postpartum hemorrhage. Big babies sometimes can definitely pose some complications in pregnancy. There are ways to mitigate that, and there are ways that we can have healthy pregnancies and good births with big babies, but we do know that it comes with an increased risk, as is on the opposite side of that spectrum, having a very tiny baby can complications. It's a spectrum there, but what are we seeing in terms of AFE specifically? If we have a bigger baby, should AFE be a little bit more on our mind?
No. We don't have any data for that at all. And there's nothing in my mind that would make that make sense.
Okay.
I'm gonna say if that makes sense. Because if we're looking at, again, amniotic fluid fetal material within circulation, I think it's much more, it's an inflammatory reaction. So I'm curious about, and I'm sure other inflammatory markers, like how are ours different? Like how is the person who has an amniotic fluid embolism and that particular pregnancy, because again, this is important for listeners, and I apologize because I think people are always looking for a way that like this won't happen to them. Totally. So they often will, which is totally fair. So they will often ask the question of, oh, if I've never had it before, then I'm good. That's not the case. So you can have an AFE with your first baby like me. You could have an AFE with your sixth baby. You could have an AFE with your third baby. You could have an AFE with your first child and keep your uterus and go on to have more babies without complication. We have around 100 survivors who have done that.
What is the survival rate?
Really ranges. We are definitely seeing, I will say anecdotally, but I do think there are some numbers here, but anecdotally, I will say we are seeing more survivability now. So it used to be like a fatality rate of like 80%. And we're seeing that drop closer to between 20 and 40.
Okay.
Yeah,
That's good. Do you
really good.
think that recognition of it is just
Yeah.
getting better? Awareness is just getting better. Our protocols are getting better. The research, while it is still very minimal, it's getting better. We're doing more. You guys have the AFE Foundation that's funding a lot of research, that's doing a lot of this stuff. Do you think that's why we're starting to just learn more about it?
I do. And while I want people to understand how severe it is, and I want people to understand the catastrophic nature of it, I also want healthcare professionals to know that it's not a death sentence because that has often been something that we've come up against. And I just had, oh, I was so angry. I just had someone come into my comment section, not at her, that said, oh, in my recent nursing education, my professor said, I'm not even going to cover AFE because there's nothing you can do.
What?
Literally said,
Why?
I'm not even going to cover AFE because there's nothing you can do.
Oh no, which just sets our healthcare providers up for failure because now they're coming in with this idea of like, all right, there's nothing I can do. And also, even if there was, I don't even have the skills to do it. I don't even have the knowledge to do even the minimal things that I could do. Oh no.
Because I think for providers, it's so frustrating. And I get it. I get the helplessness because sometimes, and this is the thing with AFE, sometimes you can do everything perfectly
And it still doesn't work out.
and the person or the baby will not survive. And that's the hardest part of this work is that each month People Magazine just shared an article of one of our moms who died in April who gave birth to twins, and her twins survived and she did not. And I have no doubt that she got incredible medical care
Mhm.
and that those providers did every single thing that they could. And so we have to be careful not to say it's not a death sentence, and sometimes we can do everything in our power perfectly, and the outcome still isn't what we had hoped. Because AFE is just one of those catastrophic conditions that we don't know how it's going to go and who gets to survive, which is beyond unfair.
It's a really tough place to be. That must be so hard as a medical professional. I think that our medical professionals, I love our medical professionals and I respect medicine and I recognize how important it is when we need it. And I think that there's some low level trauma that all of our medical professionals come in with because they know just how bad things can get, just how quickly. And at the end of the day, it's always in the back of their head, even for people like you who had a perfect pregnancy. So by the textbook, you thought you had a big baby. Your medical providers were saying, not really. That's so common. It's so normal, dare I say. And still, this happened. That is so tough for everybody, for consumers for sure, but especially as medical providers, I think that must just be one of the toughest places to be.
Yeah, you saw us at A1 at our table. Like it was
Mm-hmm.
just like tears because
Mm-hmm.
no, my opinion, and I don't want to overgeneralize, but it is very rare that a provider is going to leave an amniotic fluid case, an amniotic fluid embolism case unscathed, not
Mm-hmm.
traumatized.
Mm-hmm.
Whether they like admit to it, feel it or not, especially in cases where the patient survives, there's a lot of, I don't think my OB maybe fully recognized how traumatized she was because my outcome was so good
Wow.
until maybe more recently.
Totally. Birth is intense, and I will say
Mhm.
that even at quote unquote good births, me as a
Yep.
doula, I sometimes walk away with trauma and feel like I wish I had done things differently, or I wish that doctor had not said that, or I wish that nurse had not done that. There's, you know, trauma is so subjective too. It's like very much perspective based. It's very much how
Yes.
do you feel about what you have witnessed or what you have gone through. And I just want to recognize like that trauma is so tough. It's really hard, which I think is also for me as a non-medical professional, so easy for me to say, it's really important that our providers are doing the work to recognize their own trauma, to do some that inner work, to do some self-reflection, to work on, all right, not only have I seen some really bad things, I've experienced it. I may not have been the lead on the case, but I was part of that medical team.
Yeah.
And I think there's a place that, not in your case at all, but there's a place where providers often reach in their career of, okay, the practice that I've been doing for all these years may actually have harmed some of my patients. And I should look at that and think about how, now that I have this new information, now that I understand a little deeper, now that I understand how my actions have been landing with my patients or impacting them, I should change some things. And I just think that's really hard. Medicine is definitely an art, right? It's a balance of so much. And look, I'm not a medical professional for a reason. I would never want that
Right.
responsibility. I didn't go to medical school, not because I
Right.
couldn't do the work. I totally think I'm smart enough to be a doctor, but I don't want that responsibility. I don't want to have to see things like this. I don't want to have to be in charge of people's lives. That's a really big responsibility, and I don't think everyone's cut out for it. Me being one of those people, I would never want that. So that's so tough. Okay, earlier in the episode, you had talked about, I want people to know what they can do to advocate for themselves in pregnancy and in labor. If this is such a thing that is so unpredictable and we really don't know who it's going to happen to and when it's going to happen, how are we advocating for ourselves? What do people need to be thinking about and considering? Are there things we should put on our birth plan? Are there questions we should ask our provider? What does that look like?
Yeah, so the first thing that I want to start with is that there are two camps that come out of birth experience, maybe.
Okay.
Yeah, I think you'll understand what I'm trying to say in a second. So a lot of people will come out of an amniotic fluid embolism, myself included. This is when I first came out, and are like, why would you ever birth outside the hospital?
Got it.
Like, why would you ever do and become very strong about that? And then we have people who are traumatized by the system be like, how could you ever birth inside the hospital?
Got it.
That's such a poor decision, right? So we've got trauma playing on both ends here. And really, what it comes down to is an amniotic fluid embolism, just like anything else, is a risk
Mm-hmm.
going into birth. It's incredibly rare. And so we're weighing our risks and benefits here. I don't think that everyone needs to birth in the hospital. That's my personal opinion. And I also understand both sides of that. I understand why people are like, how could you ever birth in the hospital? And people are like, you should always birth in the hospital, right? I get where that comes from. But really, it comes down to the risks and benefits. And these are the conversations that we need to be having with providers, with birth workers, because sometimes I will have clients who are freaking out about whatever the complication is. I wouldn't say clients, I should say people who come into my comment section and are like, how do I talk to my provider about this? Oh my God, oh my God, oh my God. Or what do I do? If you can't prevent it, you can't predict it. Now I feel helpless. And I'm like,
Exactly.
no, you should go talk to your provider and you should say, hey, I get this is rare, but what do you guys do in the case of an amniotic fluid embolism? What do you guys do in the case of a maternal code in general? How does that work in your unit? Who responds? And what are the protocols for hemorrhage? Do you have a hemorrhage cart? What does this look like? And so sometimes what providers will do, especially when it comes to amniotic fluid embolism, is they will quite literally say, we don't talk about that
Oh, no.
because there is this suspiciousness around, like, AFE is such a weird thing. If you ask about hemorrhage, I think they would answer. If you ask about like maternal code's a little iffy,
Okay.
but that's a red flag. Another red flag is if your provider says that'll never happen to you.
Oh,
And I try to help. And what I mean by red flag, I don't mean that's, oh, leave your provider immediately. You should push a little harder. You should
sure.
say, hey, I see that you're trying to reassure me. And while I super appreciate that, what's more reassuring for me is to know what you would do if it does happen. It's not super reassuring for you to tell me it won't happen to me because it has to happen to someone.
Ugh.
I know that feels icky. I know that feels icky.
It
It
doesn't
feels a
feel
little.
icky. I felt that in my spine. I mean, it just look at I just have full body chills the way that I usually phrase this is it's sheer statistic. It is going to just happen to somebody. But yeah, no, that's tough. That is tough.
Yeah. And of course, we don't want it to be us. And I think the reason we avoid it is because of that idea of speaking it into existence. I just don't believe in that. I don't believe in like mentioning an amniotic fluid embolism is somehow going to make you have one. That's magical thinking in
Yeah.
psychology. That's like OCD, which, like, please, I've had that before. I'm like, I will not talk. I will not say that out loud because then it will happen. But for providers to not be able to offer, again, if their knee jerk reaction is related to their own stuff, we can come back and say, hey, I hear you, that this is a hard topic to talk about. That reassurance isn't helpful for me. What's helpful is knowing what your protocols are and for me to know that you have protocols in place. What is it? Do you guys know how to run an MTP? They will. That'd be crazy. But really reminding providers that the reassurance comes in knowing what they will do if the bad thing happens. I'm gonna go get a colonoscopy and I'm gonna call and be like, hey, so what happens if I were to go into cardiac arrest during this colonoscopy? That's crazy AF. I know that. It's my own medical trauma, but I still want to know, what would you do? And if you're like, oh, that'll never happen, that doesn't reassure me because it
Mhm.
has happened to me. So tell me what your protocols are.
Do you think that might inform someone to change facilities if they hear that maybe their doctor is not willing to talk about it, or they're not necessarily comfortable with the protocol that their doctor has shared with them? Do you think maybe it would be worth considering birthing at a different place, or even at your next prenatal, having an additional conversation and saying, look, I did not leave our prenatal feeling super reassured. And I thought maybe I could sleep on it. I thought maybe I could talk to my partner. I've even reached out to my mom. I talked to
Yeah.
my sister about it. I still don't love how we left the last conversation. Could we talk a little bit deeper about what that would look like if I experienced even this very rare thing?
Yeah, I think that's the perfect way to handle the conversation. And yeah, I do think there's something to be said about a provider not willing to revisit it. And the other part of that, right, I think you had were saying in there is, what if a provider says, we'll do the best that we can in that situation. We are a small facility, so we would just have to try to stabilize you and transfer you out. That's fine. But I say that's fine, and that's a valid answer. And
Totally.
then you have to do the whole risk benefit thing because I will get people in my comments who are like, I would never deliver in a facility that doesn't have ECMO. There's a there's not a lot of facilities that have ECMO.
Yeah. You might have to
So
drive for that
like
kind of care.
so listen, I hear you. That is someone who has, and that's fair. That is someone who has a very low risk tolerance.
Hmm.
So that's me now.
Hmm.
If I were to
Hmm.
ever have another child, I would never deliver in a facility that doesn't have ECMO because of my trauma. But that's not everyone else's trauma to carry. The fact that it's very unlikely an amniotic fluid embolism will happen to you is important to take with you in that risk benefit analysis because there's always a give and take. What are you giving up to deliver at a facility, a very academic facility, because those are the facilities that have ECMO? What does that mean for your care? You've got residents now.
Mm.
You've got, right? So there are different, and residents aren't bad. I didn't mean it like that. Sorry. I meant like there are a lot of people involved in your care now when you're at an academic institution. And it is a different vibe and feeling than delivering at more of a community-based hospital.
Totally. Totally. Okay, your AFE happened when you were 10 centimeters and starting to push. Did you ever get to the pushing phase? You
No.
never ended up pushing. Are we seeing that it happens later in labor? Is this something that can happen in pregnancy? Can it happen anywhere from 0 centimeters to 10 centimeters? Should we really be in the front of our mind during pushing? What do we know about the stages of labor and or pregnancy in terms of AFE?
Yeah, so we see it in all, like at all times during labor. It's
Okay.
specifically during labor. Now, I'm not saying we've never seen it outside of labor. So a couple of places we do see it are during DNCs,
Okay.
DNEs.
Mm.
It's a possibility. We see it way less during those types of things, but it can happen. Anytime we're doing any sort of procedure, there is a risk for something like an AFE. Again, teeny tiny risk, but still there. But more so, we see it during the run of labor or birth.
Okay.
So it can happen in a vaginal delivery, it can happen in a C-section, it can happen with forceps, with vacuum, without, completely uninterrupted vaginal birth. We see it happen after birth.
Wow. Like once
Immediate,
your baby is out, you're back in your L&D room or you're on postpartum and now we can have an AFE?
not quite that far. So I believe the criteria is within 30 minutes of the delivery of the placenta.
Okay.
It's usually like immediately following birth. Like the way that I hear it very often depicted when it happens in this way is like they deliver the baby and within a minute or two, they start to struggle to breathe.
Wow.
And then it progresses from there. So that is definitely, and that's the one that I think people are like, oh, that's great, like completely normal, smooth vaginal delivery. We also see it in C-sections, even when they're planned. Sometimes amniotic fluid embolism can happen. And
Mm,
then we see it at like water breaking.
okay.
See it at water breaking. We see it again when other things are introduced, like an IUPC. These are just, and as we're talking about this, I need people to understand that this is rare.
Sure.
So we're seeing it happen. When I say we're seeing it happen, when AFEs happen, there is often something else going on, whether it's pushing the baby out, whether it's something else is increasing the risk of that kind of amniotic fluid or fetal material.
Yeah. At A1, you guys had talked about like this perfect storm of all the things
Yeah,
lining up. Can you talk to us about what that perfect storm would be?
I wish I knew he.
Oh, we
If
don't
we
know.
knew,
We don't have any data on that, huh?
no, if we knew the
Mm,
perfect, if we knew what caused AFE, we'd be like in a heck of a lot better of a situation. So no, we have no idea what the perfect storm is. It's odd that it typically only happens in that specific pregnancy and birth.
mm,
So there's something about that specific, maybe placenta,
okay.
that specific fetal material. These are all guesses. These have
Sure.
nothing, these are not based on research. And the person, right? We have something, some sort of immunoresponse that happens. And there's got to be something unique
Sure.
about the individuals that this happens to. And there's something unique about the reaction because not every AFE is catastrophic, but not every AFE is the same level of catastrophic. So we do see some people, it's like Miranda, who's the executive director of the AFE Foundation, describes it a bit like a bee sting.
Okay.
So sometimes people get stung by a bee and it hurts. It is not fun. It is not good. So still catastrophic, still having respiratory distress and things like that. But it's not like their whole arm blows up. And so we have people who will recover from an amniotic fluid embolism, like a 24-hour turnaround. Like they'll be extubated within 24 hours and like recovering pretty quickly.
Mm,
And some keep their uterus, some have a more minimal DIC. It's still clearly an amniotic fluid embolism, but it's just not as severe, even though I want to make sure to express it's still very severe. It is still a life-threatening catastrophic event, but some turnaround times are quicker than others, and some maybe don't go into full multi-system organ failure.
needing ECMO, or does pretty much
Exactly.
everybody need ECMO?
No.
Yeah.
ECMO, the use of ECMO is rare in amniotic fluid embolism, but we are hopeful of its use saving moms that I think maybe wouldn't have survived. No, I know wouldn't have survived, right? We wouldn't have survived without ECMO when they weren't maybe using it as much 10, 20 years ago.
Sure. How often do we see fetal demise with AFE? We've talked a lot about moms passing. We know that it poses a threat to babies. What does that look like? Are we more so often seeing moms pass and babies survive?
So I know that the last time I checked the research on this, the rate of fetal demise when the baby obviously is still in utero during an AFE was up to 65%. Now, that being said, I think that this is a situation where teams who are more prepared and more educated on maternal codes are saving babies because they recognize that getting the baby out is also helping keep the mom alive. So when we get the baby out, we are essentially allowing for better cardiac return. So when we're doing CPR, when we're doing compressions, they can be more effective when there's not a massive baby inside the uterus compressing some of those really important arteries. So when we talk about if we haven't had ROSC, if we haven't resuscitated the patient, the pregnant patient within 4 minutes, then we need to cut. We need to do a bedside C-section. That is for the sake of the mom or the pregnant person as much as it is for the baby.
That makes sense. Anytime that you're keeping two humans alive, it's going to be easier to just keep one alive, right? Your
Yeah.
body at that point is essentially going to have to choose between you and your baby. And so, if we can get your baby out and we can stabilize them on the outside, then letting your body just focus on you makes so much sense. Do
Yeah.
you find that either you or other survivors have long lasting medical implications? So, you had just shared that when you go to your colonoscopy, you're going to be that weird lady that calls and says, what if I go into cardiac arrest? It's going to be the first time that front desk lady has ever heard that
Yeah,
question. She's going to be like,
for
what
sure.
is going on with this
Yeah.
patient? Her
Like,
down is anxious.
yes.
What do you find either mentally, emotionally, or physically, what kind of repercussions are we seeing after FE with our survivors?
It is all across the board
Okay.
because AFE is so poorly understood in
Okay.
its like impact, again, with their
Mhm.
lack of research. So not everyone is going to have a massive issue with their heart like
Mhm.
I did. Not everyone is going to, because the run of treatment is so different too. So what you need, what your team decides, like there are so many factors that go into how you survive if you survive. And so some people will have, and your body, like some people's bodies just react differently to these types of things. And some people have really bad issues with their kidneys and they'll need dialysis for a while. We've also had people who have needed full kidney transplants post.
Wow.
AFE. We have people who, of course, have a hysterectomy. We have lots of complications from ECMO survivors. So some people will lose legs, unfortunately, because
Wow.
of blood flow issues. We have people who have strokes is a big one. So DIC is a bunch of clots. And so that can end up causing strokes as well. We have lung issues. I had a bunch of chest tubes because I had collapsed lungs. Yeah, there's any organ, pick it, and we've got issues with it. We just did a panel or a webinar the other day through the foundation on GI issues after amniotic fluid embolism.
Wow.
Yeah, so
Wow.
there's,
So basically, any part of your body could fall victim to AFE repercussions.
yeah, because it's a
It's
full
so systemic.
it's multi-system. Almost everyone who has an AFE goes into multi-system organ failure. It just depends what part of your body takes the brunt of that. And often the treatment that we need for certain parts, I'm sure part of the issue with my lungs and heart was like fluid overload too. But I wouldn't have survived without the fluid overload, blood product, etc. There's risk benefit to all of these things that we have to do to keep someone alive. And yeah, and I actually have, for the most part, I would consider like zero long-term complications from my
Okay.
amniotic fluid embolism. I still do like lots of monitoring stuff, but for the most part, I really don't have issues, which is rare. Now, mental health wise, that is where we see a significant, obviously, a significant impact after an amniotic fluid embolism for a myriad of obvious reasons.
Totally. Just that trauma, right? Of I shouldn't be here. I died and came back. I experienced something so traumatic. I'm very alone in this. If there's only a
Yep.
hundred of you a year, you can't look around and be like, oh, I have a lot of people that understand me. Hardly anyone understands because hardly anyone has experienced what you've experienced. That must
Yeah.
feel very isolating.
Yeah. And it's very hard to, I shouldn't, it even makes me feel guilty saying it's hard to survive something because, of course, we're grateful. But that's what comes along with it is the feeling of not really being able to have space for other emotions because
Mm,
you see every few months that someone else is dying from the thing that you were saved from. And it's hard to know that, and it always makes me, you know me, I'm an emotional person, but like when I talk about this stuff, I'm pretty like, this is what I do. But it gets me emotional, really emotional to think about all of the families and all of the kids that are growing up without moms.
just a level of guilt Comes along with that. Whether it is rightfully, whether you should feel
Totally.
guilty or not, it's
Doesn't
there
matter.
regardless. Yeah. Oh, that's so tough. Okay, I have a question about your family members
Yeah.
because that is traumatic to watch your daughter go through it, as your husband, to watch your wife go through it. What, talk to us about that? I guess I don't have a specific question other than like,
Yeah.
how was that experience for them? And then what are we seeing now that you guys are a couple years out from this?
Yeah, it's pretty horrific for family members in a different way. I like wasn't there. So I didn't and I don't take away any of my own trauma. I take up space with my trauma and my grief. I'm not afraid to, but I really wasn't there. And my family was. And my mom was actually in the room with us right before. And was it you who asked me that if I thought that it was like a little bit of divine intervention? That, yeah, it was you. Yeah. So I'll talk about that in a second. And I do believe it was. So my mom was in the room when I was like 10 centimeters, and my husband, I don't remember this, but had asked if my mom could stay. Now, my mom and I are like borderline enmeshed. So I was like, heck
Okay.
yes. The only reason that she was not was I was trying to like respect my husband's boundaries and like, we're going to just do this together, just the two of us. And after 2.5 days, my husband was like, I need support. Like, I am out of my league here. Like, seeing me in pain for that long was hard. So I'm sure I was like, hell yeah, let's have her in here for the birth.
Call my mama.
Yeah. So she actually went to the waiting room to tell my dad that she was going to be in for the birth. And when they were in the waiting room, my husband actually ran out to the hallway at one point and screamed for a doctor. And they heard that. And one of them said, was that Steve? And I think my dad was like, no, I don't think that was Steve. I was like, it sounded like his voice. And then they heard a rapid, which was the first thing that was called for my room, a rapid response. And then they looked at each other and they were like, we don't know what that means. And then they heard code blue, room 230. And they were
Mm.
like, what the fuck? And so where the waiting room is in the main section, so they saw all the critical care team run by. And my mom actually tried to get out of the waiting room, and the desk attendant was like, you cannot go back there. And it always makes me so sad because she was like, you don't understand, that's my baby.
And my
And
question about divine intervention was, do you think it
yeah,
was divine intervention that your mom was removed from that and did not see you in that
100%.
situation? And you feel like that?
And it's interesting because I've told that story so many times and I've never considered that. And no one has
Mhm.
ever asked me that question. And knowing my mom and how utterly traumatized she was by this experience, I cannot imagine if she had seen me go into cardiac arrest. Like I know she would have recovered, she would all the things, but I think it would have been even harder. So yeah, so then she was the first one that came back. It's really interesting, just as a side note, when it comes to trauma, when you talk to my family about these events, they all have different stories.
Oh, like different perspectives, different perceptions of it.
Like timelines are totally off. Like I correct them based on my medical records. I'm like, that's totally not what happened. But that's how their brain remembers it. So like my mom and Steve were the two like biggest players because they were, that sounds weird, but like they were the two who were there for everything.
Mm-hmm.
And their stories never line up, which is hilarious.
Mm.
And I do know what did happen. And then my OB will have a different, my OB's story never lines up with theirs either.
Wow.
And so what happened was my mom was the first to come back to the room where Steve was. And she remembers that he was just like walking back and forth with his hands on his head saying, please just save my wife.
Oh.
I know. But then my dad was in the waiting room because he wanted to wait for my brother who was on his way because I was 10 centimeters. So we had called everyone who was like a
Mm.
few hours away. So my brother walks in with like his Starbucks for my mom in hand. And, or actually, it wasn't my brother yet, it was my best friend. My best friend was also on her way. So my best friend walks into the waiting room. And the way that she describes it is she's like, I saw your dad slumped over in the corner crying with someone sitting next to him who I didn't know. And it was the chaplain.
Oh my gosh, which is so traumatizing. You see that person and you're like,
Yeah.
what has happened?
Yeah.
Things are really bad.
And my dad doesn't, this sounds like very stereotypical, but he's just like not a crier. My best friend's never seen him cry before. And so he got up and hugged her and just said, "It's Kayleigh and the baby. We don't know. We don't know." Because no one knew what happened at that point. They just knew it was a code blue. So then my dad was like, "I really have to go back to the room. Can you be here?" And Jessie wasn't allowed back because she, quote unquote, wasn't family. And so her and her boyfriend at the time, who's her husband now, sat in the waiting room. And then my brother and his wife showed up with their Starbucks for everyone. I'm happy to meet the baby. And Jessie was crying. And it's like the whole thing like repeated itself over again. And yeah, so then my brother and his wife went back to the room because they were family. And my best friend was still left in the waiting room watching just like coolers and coolers of blood run by the waiting room windows. And there were texts that you could see that were sent the first initial time that my OB talked to my husband. They had actually brought him closer to the OR. So they didn't tell him anything. They just said, "We're going to walk you down." And so he had the social worker and then the chaplain on either side of him. And he was walked down to this really small room. And this was like a bit of a miscommunication that I think maybe could have been better. He thought they were going to tell him that I had died because they brought him like all the way down, sat him by himself with the chaplain and social worker on either side of him. Thankfully, they didn't. They told him I had an amniotic fluid embolism, that the baby was okay, and that I essentially was not. But yeah, so from there, my family was told like several different things. Like that was the first information. And then they went back. My husband went back to the room and told everyone that I had an amniotic fluid embolism. And the chaplain told everyone not to Google it. And so my mom Googled it right away.
Naturally.
Which is totally what I would do.
Obviously.
Because like when you Google it, it's not good. It's nothing that is said is good. So that was the like first initial situation. And then when my OB came in and told people to pray, like that was, all of the men in the room were crying. It was just like my mom remembers thinking like, I'm gonna have to plan her funeral.
Oh my God.
Which is I think my mom feels bad about that. And I was like, I would have thought the same thing. That's the kind of intrusive thoughts that come up, like what, yeah, like how. And so my family is amazing. They are like the only reason that I made it out emotionally in the way that I did. My husband slept in the CTICU room every night. And then when I was conscious, he and my mom switched off because he needed to sleep. And so they would go to the hotel the night that they like weren't on Kayleigh duty. And Kayleigh was very anxious and needed someone by her side at all times. One of them had to sleep with me. And sleeping meant talking to me until 3 a.m. because I was not sleeping.
Oh, yeah.
There was no sleep happening at all. But they were really incredible. The care team. So these are the things on the back end that I would consider. It sounds extreme. It's like me asking the colonoscopy people, if I'm going to go into cardiac arrest, like, what's going to happen? What are you going to do? It sounds a little extreme, but I do recommend people think about what you want in these situations. So making sure that your family knows that you want them to fight, if it is medically possible, for your baby to be on your chest, skin to skin, in the ICU. I am a medical person. Western medicine, like when it is needed, it is the most amazing thing. I think I turned around so quickly on ECMO because my child was on my chest, skin to skin, while I was on ECMO 24 hours after my amniotic fluid embolism. And there are a lot of concerns that people have. And now if your baby's in the NICU, most AFE babies who are still in utero are going to be sick and in the NICU. So I understand it's not always possible. When it is possible, medical teams need to make that happen right away. I was by no means like stable on ECMO, but I was stable enough to have my baby on my chest. So that's something I would put somewhere, write somewhere. Feeding is another thing that I would put somewhere and write somewhere. If you are intubated and sedated, what do you want? Because that is a tricky situation, to say the least. I get a lot of flack for this when I share it on social media because nurses are amazing and most of them understand this, but I think a lot of nurses are unable to hold two truths at the same time when it comes to this, which is that my goal was to breastfeed when I thought I was going to have not a deathly delivery. And so they did what they thought was best, which was correct, which was to pump me while I was unconscious, to try to keep my supply up, because the last thing they had heard from me was that I wanted to breastfeed. I do not fault them at all. However, I have feelings about being pumped while I was unconscious. Not that they did something wrong, I just have feelings about it. It doesn't feel good to me. Now, other people, it may feel great to them. I also was not, the conversation wasn't really revisited with me when I became aware and conscious. So no one said, hey, things have changed. How are you feeling? If you want to breastfeed, we are going to support you like crazy. We are going to do all of the things. If things have changed so much that this feels hard and not like something you want to have on your plate right now with everything else, we also understand that, and your baby will be okay. That never really happened. I cried through every pumping. I had fractured ribs and chest tubes still in. But I thought that like I had to be a good mom because I had already fucked up the whole other part of this situation. So this felt like the only thing that I could do, which is a really common theme in birth trauma world. But it took my mom and my best friend pulling the lactation consultant aside and saying, she's not listening to us. She's killing herself. We need you to tell her, not that she has to stop, it's her choice, but that if she would like to stop, that it is okay.
That you can, not that you have to, but
Nope.
that you can.
Yep, because it's not about telling people what they should or shouldn't do. Because for some people, the need to do this in this situation is so strong that they have to. There's trauma behind that, but like someone discouraging them would feel just as invalidating, if that makes sense. So we don't want discouragement. We just want to revisit the conversation and we want to talk about it, because the background knowledge here too for my situation is that no colostrum milk or anything was fed to my child or able to be fed to my child. My milk never came in. I feel like I should have been educated about blood loss and milk supply. Not that it's impossible. There are lots of people who have hemorrhages who can breastfeed, but hey, this can happen. This can have an impact on your supply. So let's talk about what we can do about that. That was never talked about. So I felt like I was really pummeling myself and no one told me that my son wasn't getting the colostrum or the breast milk. So I wish that just would have been a more transparent conversation around that. And then when I went home on Eliquis, which is a blood thinner, which you cannot breastfeed with.
So is that why your milk that you were being pumped in the hospital wasn't given to Cal? It's because of the medications and the treatments that you were having had compromised some of your milk, and not some of, but had compromised your milk, and it just wasn't safe to give to a baby.
Correct. Yes. So there was just no communication. The LC was pumping me with the intent of giving it to the baby. And then the pediatrician would come in and say, the milk is not safe. We can't do that. But it wasn't getting down to me.
Totally. Wow. That's tough.
Yeah.
I hate to put something on this, like our birth plan, because it is so rare.
I know.
But would you say to maybe put this on your birth plan, or even to have a separate birth plan? If an emergency happens, here are my wants and my desires. Yep. It's almost, as terrible as this is to say, it's almost like a will. If I'm not conscious and able to make these decisions, here is what I would want to be done to me and for me.
Yep. Because I think that actually would have taken away from me a little bit of the violation that I felt. Again, not on behalf of the nurses. I truly think they did the best with the information they had at the time, and they should have done that to give me the option to breastfeed. 100%. But I think there would have been something about so much. I think people have to understand this context too. So much had been done to me without my consent to save my life. Would choose 1,000%. Again, two things existing at the same time, would choose all of those things to have my life saved. I also didn't get to choose. I didn't get to choose to say, yep, do the hysterectomy to save my life. I didn't get any choice. I didn't get any say in all of, I had 5 abdominal surgery. Like I didn't get to say, yes, do this to my body, even though I would totally choose it. And I'm so grateful I had a team that did all the things to save my life. But
Sure.
this just felt like another time that I didn't get to make that choice. And so had I written it somewhere, I think that maybe would have taken a little bit more of the like violate feeling out of it.
Yeah. So how long were you actually in the hospital postpartum? And then what was that transition home? Did you transition with any sort of medical machinery? Did you have a hospital bed at your home? What did that look like?
So I was very lucky that I was 29 and pretty active at the time because once I got over the hump of not being able to stand, not being able to walk, I was like golden. Like I was walking upstairs, I was good to go in a sense. So I did have a home health nurse that came every day to pack my incision because I had some pretty significant tunneling, so some holes in my incision. And that took a solid month to close. So they would come every day and pack my incisions. But I was able to shower myself by the time I went home. I was able to go upstairs and sleep upstairs. And then I would just try to limit how many times I had to go up and down the stairs throughout the day.
And what was your total hospital stay? How long?
14 days.
Wow, 2 weeks. I think a lot of people probably hear that and they're like, wow, that's so much shorter. I think a lot of people probably
Yes.
envision that you had stayed in the hospital for weeks and months on end.
That's what they projected. That was the first projection was that I'd be on ECMO for at least 2 weeks, which is why I think again the skin to skin had something to do with that. And then I'd be in the ICU for a few weeks, down to mother baby for a few weeks, to rehab for a few weeks, and so overall it would probably be like a month or two stay, and that's just not what happened.
And is that common with AFE? So do most people experience a couple weeks or months in the hospital?
Depends on the severity. Those who are on
Yeah.
ECMO, I feel like, yeah, it's usually around at least like a month.
Okay. Just for that process and the body to heal and for
Yep.
your medical team to continue to monitor you and all of that.
So, more so, there are typically hiccups along the
Okay.
way. Like the way my team put it to my family when I was still on ECMO was like, we're going to take 2 steps forward and 1 step back every time we do something. And that was not what happened. Again, just like luck and my body reacting well. But that's usually what happens. There's usually like issues with ECMO, there's issues with infection, there's issues with that keep you there longer, more surgeries that are needed. And that just, again, I got very lucky and didn't have any sort of lingering issues.
Yeah. That's good. That's really good.
Yes.
Who took care of your baby while you were still in the hospital, and what did that look like? And is that anything that you guys had talked about beforehand?
No, and I wish that we would have.
Really?
Um, yeah, it created a lot of family conflict because everyone was traumatized. But my parents, like I said, are amazing. And so they came and stayed with us for 6 weeks
Mhm.
and helped.
Mhm.
But we were all traumatized.
Mm.
And so it wasn't we were just like swimming in trauma soup. So there was a lot of irritation, a lot of anger, a lot of frustration, a lot of tension, to say the least.
That's probably to be expected though, right? When you're
Yes.
in a really high intense situation and also something that was very unexpected,
Yep.
and in addition to those 2 things, it was a life or death situation.
Yep.
Humans go into survival mode. We're just trying to survive. We're just trying to get from 8 a.m. to 8 p.m. and keep everyone in our life alive and as well as possible. So that makes a lot of sense to me. So much sense.
Yeah. Yeah.
That's tough.
Yeah.
Oh my goodness. Okay, this has been so insightful. And I know, listeners, I know this has been heavy, and I know this has probably been a lot of information that you've never even thought about. And part of this podcast is to bring you information that you've never considered before so that you can have a more empowered pregnancy. And I want you to know about the good things and also the less desirable things so that what we said in the beginning of the podcast, you know your options, you know how you can stay in control, you know how you can prepare for these things. So I think my final wrap up question, Kayleigh, is ideally, what would we want to see in the future in addition to more research? Are we hoping to have maybe some sort of test or screening for those markers that you were talking about? Are we hoping that we can start to maybe identify people who are at higher risk, and what would that look like?
Yes. And this will be my plug for how we're going to do that, which is through basically pathology, right? Through samples. So, what that means is we are asking for providers, for nurses, for whoever who is responding to a maternal code, if you have any inclination, any thought that it might be an amniotic fluid embolism, to grab a red and a purple top. So these are like blood to pathology tubes. I don't know how to say it, whatever. For lay people who are listening, they're just how we take blood. But
There's little tubes that they hook up
yes,
to your IV,
yes,
and that's what your blood goes
yes.
in.
So we're asking them to just grab a red and a purple top and put it aside. You don't need consent to do that. We will consent the family or the patient later on. We need that to be done before any blood products are transfused.
Oh.
And then you can call the AFE hotline and we'll take you through everything that you need to know about that. You can also call the AFE hotline for like help, like clinically support, any of that. And then also through education, we have an entirely free course that is done by the wonderful critical care and obstetrics ladies, an MFM and a wonderful DNP, as well as Miranda Clausen, the executive director of the AFE Foundation. It's free. It's 3 CEUs, and you can get it at amnioticfluidembolism.org, because the more we are educated and prepared, the more likely we are to be able to save patients and their babies.
That is so awesome. Oh my gosh. Kayleigh, truly thank you so much for sharing your story. I know that every time you share this, you must relive a little bit of that trauma, and there must be a balance of, okay, I'm helping spread awareness, I'm helping people understand, but also there is that piece of, I went through something very traumatic. I think we all have trauma in our life, and we all can resonate with the fact that anytime you revisit that traumatizing situation or story or experience, it does a little bit bring you back to those feelings, right? So I want to just thank you for being here, for sharing your story, for doing the hard work that you do every single day, for educating all of us. I think that you are probably one of the most pivotal people in the AFE world because of the platforms that you have and because of your willingness to share your story and to educate all of us. So thank you so much, not only for all of that, but for being here and sharing your story with us. If people wanted to connect with you and they don't already listen to your podcast or they don't already follow you, how can people connect with you and learn more from you?
Yeah, so I have a podcast, the Birth Trauma Mama podcast, as well as an Instagram community, a TikTok community, which are both at the Birth Trauma Mama, which is the Birth Trauma _ Mama.
Nice.
Thank you. Yeah, thank you so much for having me, HeHe.
Of course.
Yeah.
Thank you so much, Kayleigh, for being here. All right, you guys, I'll see you in the next episode. So be sure to follow Kayleigh on social media, and you can find me at Tranquility by HeHe or at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I truly do value this community, and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by HeHe on all platforms. Until next time, stay educated, stay supported, stay confident. Bye.